Good evening, everyone. Welcome to Procure en Parle. As information is our first line of defense, we're glad to host a fifth webinar in our series today. Today, we'll be talking about screenings such as biopsy, imaging, and the importance of PSA to facilitate diagnosis or to monitor your prostate cancer before, during, or after treatment. We're here with Chief Urologist at Cité de la Santé de Laval Hospital, the department head in urology, Dr. Mathieu Bettez. Will have a presentation followed by a Q&A. We want to thank our participants who submitted questions. If you want to submit questions during the presentations, you may use the Q&A feature to do that. We'd like to thank our sponsors, including Industrielle Alliance, as well as Astellas, and the Association of Urologists of Quebec and Canada. Procure is not only a member of the Canadian Urology Association, but also an official partner throughout the country for prostate cancer and testis cancer. So this is a great piece of news. Now, this being said, since we're going to have a great presentation today, I'd like to thank Dr. Bettez for accepting the invitation. Thank you so much. And without further ado, you have the floor. Please go ahead. Have a great presentation. Thank you very much. Give me one moment. Can you see my screen share? Great, thank you. Very glad to join you tonight to discuss prostate cancer. I do not have any conflicts of interest. And here are the companies for which I've received fees for presentations or for my role on an advisory committee. We have a lot to cover tonight, so we'll try to shed some light on the new screening recommendations related to prostate cancer, how to diagnose prostate cancer, the usefulness of imaging tests for both screening or following negative biopsies, and we'll also talk about the PSA PET test, and we'll talk about also PSA and its role with managing prostate cancer. Let's start with some facts about prostate cancer. This is a very common cancer. 1 in 8 men will be diagnosed with prostate cancer, and 1 in 29 men will die from it. This year, or rather last year, 24,000 Canadians will be diagnosed. About 20% of all new cancer diagnoses in Quebec. Over 4,000 Canadian men will die from it. On average, 66 Canadians will be diagnosed, including 12 Quebecers, and on average, 12 Canadian men will die from prostate cancer every day. So let's talk about screening. Prostate cancer is typically asymptomatic, especially in its early stages when the disease is still curable. So symptoms can show up at later stages. These symptoms include blood in the urine, difficulty also emptying their bladder. We need to be forceful and for emptying the bladder because the urethra is kind of partially blocked. We could have renal failure also due to creatinine because the prostate locally is blocking off the canals for bringing urine to the bladder. And we could have bone pain if the cancer has spread. So the idea here is to detect clinically significant cancer in healthy men early on. PSA is an enzyme. It's secreted by the prostate. It's specific to the prostate, but it's not specific to prostate cancer. This means that there are several conditions, cancer or not cancer, that can bring about elevated levels of PSA. So it could be inflammation or infection. For instance, cystitis, prostatitis, urinary retention, so having trouble urinating, manipulations, and rectal exams when we used to do that way back when, also sexual relations, possibly cycling. We also look at BPH. So with a large prostate, we have then elevated levels of PSA. The new recommendations for screening. So with the Canadian Urologist Association, we have 3 studies, the randomized studies that were carried out, and our recommendations are based on these 3 trials, especially the middle one. This was a study carried out in Europe on 60,000 men with PSA every 4 years versus no screening. So the threshold varies from one study to another, but in this case it was 3. And we saw a relative risk reduction in favor of screening. So we needed to screen about 800 people to have 1 less death. In recent years, with the U.S. Preventive Task Force that was against prostate cancer screening, we saw an increase of cancers, and the detected cancers were higher risk. This is a second chart just to show you that there are many associations and the recommendations vary. We're going to focus tonight on most recent consensus, so that of the Association of Urologists of Canada. So the association focuses and recommends on screening in a way that is, of course, based on shared decision between the healthcare professional and the patient. So when to start? At age 50 for most men, age 45 for those with risk factors, so either family history or if you are of African American descent. If you have some genetic markers, such as HOXB13, then you could be assessed with a genetic counselor. So how do we proceed? We use rectal exam and blood test. The benefits, of course, is to be reassured to not have cancer, and of course, to avoid metastases and death related to cancer. Of course, the disadvantages are simply being concerned if you have elevated levels of PSA. As we saw, there are many conditions that can lead to high PSA, not just prostate cancer. So this can induce stress and worry. There's also a negative impact of a prostate biopsy. It's a pretty invasive test. It's not pleasant at all. So patients tend to be anxious about this test. There's also a risk for overdiagnosis. We could find cancers that are not clinically significant, that will not spread, that will not cause any issues, that we don't need to treat. And this is why we do active monitoring more and more. So in this context, there's a risk. If we were to treat every patient that have a little bit of cancer cells in their prostate, then we would be doing overtreatment. So following, of course, a decision process with the patient, typically we carry out screening with a PSA and a rectal exam. Then, if the score is 1 or less, we can proceed with screening every 4 years. If PSA levels are between 1 and 3, then every 2 years, and if it's over 3, then more frequently. There is no predetermined frequency, but we need to keep monitoring this. It will depend on the age of the patient. We also look at the volume of the prostate. An MRI could help, and a nomogram could also help, where we can input data, PSA and age, to see what the risk is. We can stop screening at 70 because the risk after 70 years of age is very low, and the mortality risk was unchanged. So after 70 years of age, to not have the anxiety related to these high numbers, then it's just better to stop screening. Of course, this is always done on a case-by-case basis. If a PSA is under 1 at 60, then we can also stop screening, because the risk of detecting a cancer over 10 years is about 3.4%, and 90% of the time they are cancers that are not an issue. If there are anomalies, of course, then we move on to getting a biopsy. So I've already alluded to how we diagnose this type of cancer. So elevated PSA level or an abnormal rectal exam, in which case we proceed to a biopsy. The biopsy is the only way to diagnose prostate cancer, because this is the only way to get tissue to analyze to see if there are anomalies and if there is a presence of cancer. An MRI can help to find some indicators, some zones, but does not allow for diagnosis. So this is the current decision tree. If we have elevated PSA or rectal examination, then we carry out other tests. There are several conditions, again, that can lead to elevated levels of PSA. So we can then move on to biopsy. If the biopsy is negative, then we monitor PSA. If this is stable, then we just remain in monitoring mode. If there is an increase in PSA, then we may have another exam or another biopsy. If the biopsy comes back positive, then we move on to active monitoring. And if the cancer is significantly present, so clinically significant, then we'll move on to treatment. What is the biopsy? Again, this allows us to assess the score. It's called the Gleason score. This allows us to give a number to how aggressive the cancer is, if there is any cancer. The biopsy can determine the type of prostate cancer. There are various types of tumors that we can see, and these can affect the prostate or other organs. So this biopsy helps us to know how to properly treat this cancer. MRI could precede the biopsy, or we could have some biopsies to see if there are zones that need attention. The norm still is transrectal biopsy. We go sampling up the prostate. This may miss up to 20% of cancers. This is significant. So even if we have a negative biopsy, we need to do some active monitoring of the PSA. Then if PSA levels increase, we can move on to either a biopsy or MRI, so that we can keep a close eye on this. The cancer grade may be underestimated as well, because these are very small pieces of tissue that is analyzed. We could have a targeted biopsy. These are carried out after an MRI. This is where we can see some abnormal changes. There are 3 targeted biopsies. It could be MRI with cognitive fusion. This means that the surgeon or radiologist carrying out the biopsy will look at the MRI, look at the picture, and will carry out a standard biopsy. And they take more tissue where the anomaly is to try to get to the cancerous cells. We could have different types of biopsies. We can see on the right, this is a suspect lesion, and the biopsy is done repeatedly 2 to 4 times over that zone in order to be able to identify any clinically significant cancer. We can also carry out biopsies under MRI guidance. This is more common in Europe, not very much here. So here we use needles to get directly to the lesion. This is a method that's not very affordable and not very accessible currently. Transrectal biopsy procedures. This is carried out in over a very short time. It takes 5 to 10 minutes. The patient lies on their side, and we use a probe through the rectum. We use analgesia, and we measure the prostate. We try to see if there are suspect zones. Of course, the MRI is much more precise for this, but we carry out the biopsy in this case, so we take about 6 to 12 samples in the high-risk zones. It takes 4 to 6 weeks to get results. These are not available in your health record. It will be available with the physician that carried out the biopsy, and also will be in the archives if you want a copy of the results. We need to discuss with your physician if you are on blood thinners or on various medications, non-steroidal anti-inflammatory drugs, or aspirin, or natural products. Now, you don't need to be fasting. It's good to have someone available to take you home. There will be an enema in some cases that is prescribed a few hours before. More and more, we use Cipro and Monurol, so antibiotics, to decrease infection. Following biopsy, we tell you to refrain from biking, long walks, and from sex. If you take blood thinners, then we need to check with the person who carried out the biopsy to know when to resume treatment. We don't want to have any hemorrhaging. What could happen? We could have perineal pain or penile pain for a few days. We could have blood in your urine, stool, or semen for a few days or a few weeks. The blood or the bleeding will just resorb. Now, there are red flags. When to consult your physician. If you have a fever, then you need to get to the ER right away. If you have a fever, it means there's a rectal bacteria that had access to the prostate in the bloodstream, and this can be fatal. If you feel a burning when you urinate, then this is also a red flag, and you need to see a physician. If you have difficulty urinating also, we need to get that checked. Also, If the bleeding is significant or worsening in your stool or urine or semen, then of course also check with a physician. This is the Gleason score chart. So you have various groups here. The Gleason score helps us to adapt treatment, either surgery or radiotherapy. The Gleason score can only be done following a biopsy. Now on to imaging tests. How do we use them? We're going to talk about MRIs that can help us assess locally any suspect zones. And we'll also talk about other imaging tests when we have a diagnosis, so we want to know whether the cancer has spread or not. Okay, we covered this. Okay. So these tests are very safe, don't really have any poor outcomes. A radiologist or nucleus will interpret the exam. It's recommended to drink lots of water to make sure that the contrast agent is eliminated properly. So again, the MRI does not tell us whether there is cancer or not, but it allows us to assess any suspect zones or any clinically significant conditions. MRI procedures are longer. They take about 60 minutes. You will be offered headphones or earplugs because the machine is noisy. You'll be lying on your back. You can also talk with the operator if you experience discomfort. You will need to be laying down on your back still, very still. And you will get an injection for a better imaging, so a contrast agent in this case. There's a questionnaire to fill out with your physician before we proceed to the MRI. We need to know about any metal implants. So if you've received any implants, any pacemaker, then you need to check with your cardiologist. If you have allergies, you also need to mention them. And if you suffer from claustrophobia, then all of these need to be taken into account. Some clinics will require enema a few hours before. Others will use a probe in order to improve imaging. We typically recommend to be fasting 4 hours before, but when they call you up for your appointment, they will tell you what to do.
Le résultat est basé sur un système
The results
PIRAD.
of the MRI is based on a PIRADS system, so prostate imaging, reporting, and data system. So we're trying to standardize how we interpret these results. There are 3 main sequences with the MRI in order to assess all these digits, and then we get to a score. If you have a 1 or 2, then you're unlikely to have prostate cancer that needs to be treated. And if it's 3 or over, then you will probably need treatment. We'll also look at the number of lesions and their size in order to then proceed with the appropriate biopsies. These are the recommendations from 2021. You see the decision tree on the screen. So if we have elevated PSA, then we'll use an MRI first. If there are some no suspect zones, then we can move on to monitoring. But if there are suspect zones, then we'll move to probably a biopsy. we can have targeted biopsies and systematic biopsies, and even with a negative MRI, the Association of Urologists of Canada does recommend active monitoring because there is significant risk. The biopsy, again, could simply miss the cancer spots. We don't have the resources in Quebec currently to implement the MRI as a first line of defense. It's already difficult to get an MRI. In Europe, they use MRI as a first line of defense a lot more. We're moving in that direction, but we're not quite there yet. Now, moving on to bone scintigraphy and scans. This allows us to see if the disease spread. So either to lymph nodes or to other organs, such as the liver, the bones, the lungs. A CT scan can also be used before radiotherapy treatment. So they draw up the lesion in order to deliver treatment to the right zone. So they need to have a planning scan in order to target treatment properly. If we use X-rays, in the case of a CAT scan, then it's a little bit different from an MRI. This is a short procedure. You'll have an intravenous catheter to inject iodine. So very important to tell your physician if you are allergic to seafood. You may feel a metallic taste in your mouth or flushing. This is related to using iodine. Again, it's very important to remain still, and the operator will give you instructions. You need to inform your physician if you're diabetic, if you have renal failure, because in this case we can't use iodine, and of course also if you're allergic to iodine. We need to make sure that your renal function is adequate before we do this type of scan. Now, with a bone scintigraphy or bone scan, this is recommended for follow-up if you have bone pain, if we believe that the cancer is progressing, if we have intermediate or high-risk cancer, so depending on your PSA levels, or there are other agents, other elements to watch out for. This is a longer exam. We need to inject the radioactive tracer and wait for it to settle in the bones. So you will be seated on a table. There is no preparation, no medication to be discontinued. You simply need to drink lots of water in order to eliminate the tracer after the exam. If the results are normal, then that's great. You can see on the right hand of the screen if there are hot spots like this. This means that there's a lot of activity there. This could be an indicator of metastasis. This is why we're trying to do this kind of testing. There could be false positives, such as a bone fracture, that can lead to ambiguous results. So it's not a black and white exam, but it's part of the recommended controls. And this can help with treating your cancer. Now, a more recent type of scan, it's PSA PET scan. So a standard PET is not good for the prostate because there's very little glucose in the prostate. However, we have the PSMA PET scan. This is a protein. PSMA, that is a protein, a prostate-specific membrane antigen. So it's secreted by cancer cells. This is a very helpful marker. It will help us to target cancer and locate cancer, even when the nodes are very small, or even if the cancer is, again, small but spread outside of the prostate. This is not a standard exam. The current studies about metastatic cancer do not rely on these scans, and we don't quite know if we're over-treating or if this is a positive avenue. More studies need to be done. So the PSMA PET scan allow us to get 3D images of the organs. We typically use gallium as an injection product for this test. This is a Canadian paper that was published by the Canadian Urology Association journal. There are several conditions, even benign, that can actually lead to or to absorb PSMA. So there could be various lesions or angioma. So we used to think that this was a specific test, but with the studies and clinical trials, we see that there are cases of false positives. There are some types of tumors, liver tumors or lung tumors, that can also react to that, but we're currently gaining more knowledge about this type of exam. These are some recommendations. There isn't a lot of data again, and we just want to make sure that there are no other conditions. But there are many cases where it's not recommended to proceed. What we need to understand is that an exam must be done to enlighten us. Otherwise, it's not useful. So currently, we're not quite sure if PSMA, the PSMA scan, will help us to make some better decisions. So we need more information about how beneficial it is. These are images of these PSMA scans. We can see over here some nodes that are at a hot spot. So it doesn't look suspect at first glance in this case. Now, moving on to the role of PSA for monitoring purposes. This is really where PSA plays a crucial role. Both with radiotherapy or surgery, the monitoring is different, but it's very useful for monitoring purposes versus screening, because we don't have other conditions that could play a role in fluctuating PSA levels. So after getting treatment, we need PSA controls. Every time you see your doctor, it could be every 3 to 6 months, then moving on to yearly. Then we can alternate between the urologist and the oncologist. And the follow-up continues for 10 years or more. So it's really important to have a good relationship with your physicians, because you will be with them for a long time. Now, for the time for PSA levels to double. So after an initial treatment, when the amounts are low, the a doubling rate can help, but not with very small amounts. This would not be a relevant indicator. We use doubling time with patients who received hormone therapy, who developed resistance to this type of therapy with elevated levels of PSA. We have new medication that we can use when the doubling time is short. So it doesn't mean the same thing at all grades of the diseases. We can't only trust the doubling time here. There are charts that we can use, and we need at least 3 values with specific dates to have a doubling time that will really be meaningful. So moving on to diagnosis, we want blood tests to come back clean. Some people will see biochemical recurrences. We, of course, look at the Gleason score. We look at any remaining cells that could be left behind post-surgery. This will help to see if the cancer is aggressive. But there could be very slow recurrences that will slowly progress for some years before requiring treatment. So recurrence is defined as for PSA at 0.2. Then we can use radiotherapy. We have various types of radiotherapy. So it can depend on various things, but recent studies are helping us to choose. So adjuvant radiation therapy is not used as much anymore. And if we have recurrence that continues in PSA increasing, then we could move to hormone therapy. There are a lot of changes regarding treatment options. Things changed quite a bit, so this is very much done on a case-by-case basis. But this is kind of the big picture here. With radiotherapy, this could be combined with hormone therapy if there are some intermediate risks. For high-risk people, we look at this every 18 months. We want the nadir to be as low as possible. So this is the result of a blood test. So we want it as low as possible, and we want to maintain that. We could see bouncing phenomenon. This means that we could see PSA even though there was treatment. So this is not necessarily concerning in the case of brachytherapy. Now, typically, we will look at PSA measurements during treatment to make sure that the dose is working well. It also helps us with patients who had both radiotherapy and hormone therapy to see if there's an increase of PSA. So is this a recurrence, or is this related to testosterone levels? So again, this is very helpful. This slide is just there to show you the progress as far as treating prostate cancer. Research was extremely important in the past few years, especially for cancers with metastasis. So if we have a quick doubling time and also castration-resistant case, we tackle things differently. There are several options nowadays. So even if the disease recurs, which is the case in about 30% of the time, there are several treatment options. This is why it's really important to have follow-up. This, of course, needs to be closely monitored because recurrence is fairly frequent. But again, there are many treatment options. So this will depend, of course, on your body, on your capacity. And of course, we always want to make sure that the treatment is bearable. I think we're at time. Okay, so the main takeaways here. Only a biopsy can support diagnosis of prostate cancer. PSA does play a role throughout your cancer journey. The results of the test will be really important depending on where your cancer is in carrying out the right treatment. So it's really important to know which test to do at the right time. And a test must bring about a change in behavior, otherwise it's useless. These are the main takeaways. So I hope this was helpful. I'm very glad to be with you tonight, and now we're going to move to Q&A. Thank you very much for this presentation. The slide before last, I can tell you that Dr. Torin will probably reuse it because we'll be talking about advanced cancer treatment mid-June. So if participants are interested, you just had a bit of a teaser here. Now, if you allow me, we'll get back to screening. We do have a few questions about that. One frequently asked question, maybe not during a webinar, but especially on our phone line, why do physicians no longer carry out rectal exams? Yes, so once we have treatment, a rectal exam is not really relevant. But otherwise, a digital rectal exam is recommended in combination with a PSA. We could have a PSA that's lower than 4, where a digital rectal exam would help us to identify cancer. So this is why it's really important to combine a digital rectal exam and blood tests with PSA levels. So don't hesitate to ask your family doctor to carry out digital rectal exam. With recent recommendations, or rather with the older recommendations, we were a little bit in a different direction, but I think we need to promote that as much as possible, especially if screening is done only every 2, 3, or 4 years. So this is really something that's really important, using both approaches. Thank you. Another frequently asked question. When there is a biopsy, are repeated biopsies when we're under active monitoring, what are the risks actually of spreading cancer cells to surrounding tissue? Yes, we do get this question a lot when patients are fearful, but there is no risk of spreading cancer cells with a biopsy. We can miss out on a cancer, but you could have several biopsies and no risk of spreading cancer cells, either locally or remotely. So yes, very important. Another question about biopsies, especially repeat biopsies. When we puncture the prostate several times to get the samples, we repeat this procedure every year or so, or 2 years, depending on the follow-up plan. So getting these samples, does that lead to issues? So there are patients basically asking us, will I get a prostate with a bunch of holes from these samples. No, no, these punctures heal very well. And we were talking about just millimeters, and the body is made to heal. It's much less invasive than any incision. So, no issue there, and no risk of fistulas either. No issue there. Even with several biopsies, we don't have any issue. It could make the surgery a little more complex, but that is ill. That is it. So, of course, it's much better to go ahead with the biopsy. Thank you for that. Another question. I read that perineal biopsy is less risky and more effective. Is this true? And if so, why is this method only available in the private health network? Well, if we look at our studies, we don't see that. In Europe, transperineal biopsies are very common. We carried out actually a study on that, and the risk of infection was very low with a combined treatment of Cipro and Monurol. So with a transperineal biopsy, we do need, well, it's a little bit of a more complex procedure, and there is no comparative head-to-head study that can confirm any benefits. So with transrectal versus transperineal, and a perineal biopsy is much more costly. So we need to have good procedures for these good results. You also talked about the MRI and its role for screening. Currently, some urologists prescribe an MRI before a biopsy, but for others, we go straight to the biopsy. The MRI is not even mentioned as an option. Why is that so? Why is there a difference? Some urologists are more open, it seems, to using imaging before the biopsy, and others say, no, we need to proceed with the biopsy right away. This is a great question. I think I gave an answer, at least partially, during the presentation. I think we're not ready yet to have just an MRI to get a good answer. Access to an MRI is difficult in Quebec, unfortunately, even for priority patients. So currently, if the system can't absorb these MRI as a first line of defense, an interpretation also of the MRIs is not always done by a radiologist. It requires specific skills, and the results of the MRI depend on the radiologist interpreting it. So in Quebec, we're not ready to use that as a first line of defense. INES is moving in that direction. We're just not ready quite yet. We'll probably get to that in the future, but I believe a biopsy is still our first line procedure. Even with negative results, we need to talk about the role of biopsy, and if the MRI is positive, then a biopsy is required. So should we have a systematic biopsy versus other types or targeted biopsy? This is subject to decision making. There is a risk of detecting an a cancer that's not clinically significant. So I think in the future, we'll move towards the MRI as a first line of defense, but we're not there yet. Currently, we should use the biopsy as a first line procedure. And we can save MRIs for the negative biopsies. Great, another question, and we do get this question a lot. So, the patient has a large prostate, according to their doctor, and this would be the cause of urinary problems. The patient says they had an MRI with PI-RAD of 1 and negative biopsy in 2019. Now, in 2021, this patient is getting more and more concerned because the APS level that used to be at 7 is now at 12. This patient is close to 70. Should they be concerned? Well, if there is an increase in PSA levels with some biopsies and MRI that were done a few years ago, then yes, we should proceed with a biopsy. If the biopsy is negative, then we could have some line of treatments to see if the PSA can be stabilized. This will help with detecting cancer, and they could help with urinary symptoms as well. We have another question. Oh, you actually answered it already. Maybe just repeating about the PSA doubling time for those who joined late, perhaps. So if someone had their prostate removed, and then a first dose of PSA was at 0.05, let's say, and 8 months later, the PSA level is at 0.1. The patient is seeing it as the PSA levels having doubled, because we're hearing about that more and more. So could you explain again, that this is not quite what the doubling time is, and that we can't really rely on that? Yes, so doubling time is interpreted differently depending on the grade of the cancer. So we can't just say, oh, the number got multiplied by 2. No, we need to use specific calculations. These are available online, some charts for proceeding to calculations. And we need at least 3 PSA results to do that. And then we can look at doubling time. So if the PSA goes from 0.03 to 0.06, does not mean the same thing and does not imply the same thing after removal of the prostate versus hormone therapy. And then there's a progression in PSA levels. So the treatments will be different. And there are more and more lines of treatment. There was a lot of progress in the last 15 years. This is great news for patients. But the doubling time, again, doesn't mean the same thing, depending on a lot of endpoints. It means something differently, that is, if people are hormone sensitive or not, if there are metastases, etc. Great. Last question. What is the percentage of recurrence post-surgery versus radiotherapy? They're pretty much the same, so we can't really say that one approach is better than the other, or leads to more cases cured. It will depend on the quality of life, and recurrence. This is what I tell my patients. So it's about, again, a 30% recurrence rate, but it depends on the Gleason score. There are several factors to take into account. But yeah, 30%, about 30% of recurrence post-surgery or post-radiation therapy. This is why it's really important to have active monitoring. All right, thank you so much. Now we're reaching the end of our time together. Again, I thank you, Dr. Bettez, for your time. You, of course, need to be here, and you answered the specific questions. So we know that you spent a lot of time on this, and this is the first time we address this topic. And we see there are a lot of participants with us that stayed until the end, so this generated a lot of interest. If there are any outstanding questions, we'll answer them this week. So again, Dr. Bettez, thank you so much. This was a fantastic presentation. I would like to tell the public that our next webinar will be held on May 24th. The topic here will be active monitoring as a treatment option with Dr. Simon Ouellet. So hope to see you there. You're welcome to have a look at procure.ca for the information. Thank you so much. Goodbye.